Okay, good evening, everybody. My name is Gideon Sandler. I'm a surgical oncologist, a head and neck surgeon and general surgeon. I have rooms in Bondi Junction. I operate at St Luke's and Chris O'Brien Lifehouse, and I have public appointments at Westmead Hospital and with the Sydney Children's Hospital Network. I'm involved in the oncological and general surgical care of both adults and children. I'd like to thank you for taking the time this evening to join this session. I know that many of you are spending time away from your families. I'd like to thank the Central and Eastern Sydney Primary Health Network and Health Direct for arranging the webinar this evening. So this evening I'd like to explore the clinical assessment, diagnosis and treatment of both melanoma and sarcoma. And I'd like to develop a paradigm of shared care between the specialist and GP for our patients. First of all, let's look at melanoma. Melanoma is the fourth most common malignancy in Australia, behind breast, colorectal and prostate cancer. Its incidence is unfortunately rising, particularly amongst our young population. The risk factors are well known to us and include fair skin, freckling, red hair, blue eyes, and UV exposure from the sun, and now thankfully the banned tanning beds, and a number of rare genetic anomalies. Outcomes of melanoma are stage dependent, but we are living in an age of rapidly developing melanoma therapies, and we are having much better outcomes than we did only 8 or 10 years ago. This young man on the right of screen demonstrates many of the unmodifiable risk factors for melanoma, although he lives in a low-risk climate. But melanoma can occur in anyone. A new or evolving pigmented lesion that has become itchy or painful, or is ulcerated or is bleeding, or merely shows a colour change is suspicious for melanoma. On examination, melanomas can demonstrate any or all of these signs. It may be asymmetrical, have an irregular border, have a changing colour, be 6 millimeters or more in diameter, or be evolving in some way. We are all familiar with the A, B, C, D, and E of melanoma. When examining a patient with suspected melanoma, I do a full skin check, making sure to examine the scalp, behind the ears, the nail beds, the palms and soles of the feet, or palms of the hands and the soles of the feet, and the genitals and the skin of the breast. A patient with one melanoma is at risk for more. Looking for regional and distant metastases is also really important. So I examine the cervical, axillary, and inguinal lymph node groups. And then I examine the abdomen for hepatosplenomegaly for distant metastases. And then I gently push on the axial and appendicular bony skeletons. A suspicious lesion should be biopsied. Ideally, an excisional biopsy should be done. If the lesion is too big to remove, an incisional biopsy can be done. It's important to note that shave biopsies should be avoided because they disturb the thickness of the lesion on histopathology, and so that critical Breslow thickness becomes difficult to assess. More on that later. Excisional biopsies can be done under local anaesthetic. 1 to 3 millimeter margins are ideal in order not to disturb the lymphatics around the lesion. This is in case the lesion requires a sentinel lymph node biopsy for staging purposes, and I'll talk about this a little bit more later in the talk. The biopsy should be full thickness, and the orientation of the biopsy is critical. For limbs, the biopsy should be along the axis of the limb, in the lines of tension. This minimises the risk to neurovascular structures, and it makes the definitive excision far easier. On the right side of your screen, the red line that you can see around the excised melanoma is the margin which is required to be achieved in order to excise it properly. The biopsy has been taken in the axis of the limb, and so the definitive excision in blue is easier. On the left of screen is a transverse biopsy, and then the blue line shows how much bigger the excision would need to be in order to achieve clear margins. Lesions like this on the sole of the foot are amenable to incisional biopsy because excisional biopsy would be too difficult to close under a local anaesthetic. The most abnormal area that you can see should be biopsied. Sometimes that's visible under a dermatoscope. Multiple biopsies can be done, and they can be repeated if necessary. When the pathology report comes back, there's a lot of information, but the most important appears in the top 3 boxes, and they are Breslow thickness, whether or not the lesion was ulcerated, and whether there were any mitoses detected under microscopy. Breslow thickness in millimeters of the melanoma is measured from the stratum spinosum of the epidermis to the deepest melanoma cell, and it plays a critical role in staging. When it comes to the definitive excision of a melanoma, the margins that we need to achieve depend on the Breslow thickness. For in situ melanomas, a 0.5 to 1 centimetre margin all the way around is required. For invasive melanomas, less than a millimetre thick, 1 centimetre margins are required, and for those between 1 and 4 millimetres thick, 1 to 2 centimetre margins are required, depending on where the lesion appears on the body. For those over 4 millimetres thick, 2 centimetre margins are needed. These margins are measured from the edge of the melanoma and are critical and are clinically measured rather than taken from the pathology report. So, for example, you might take a 1 centimetre margin all the way around a melanoma with a Breslow thickness of 1 millimetre, but the pathology report might then say the margins were only 0.8 centimetres. As long as you measured it out clinically, that's fine. For melanoma in situ, there are 3 main treatment strategies. There's surgery, particularly for extensive lesions. The surgery for particularly extensive lesions like this one can be quite morbid. You can see to the left of screen, this gentleman had a melanoma in situ on the cheek. The inner circle is the edge of the lesion as seen on dermoscopy, and the outer circle is the margin that we need to take. In order to fill that hole, we would have needed to do quite an extensive local flap repair. The patient elected for an excisional biopsy instead to make sure that the entire lesion was melanoma in situ, and then we went on to treat him non-surgically. And the 2 options for treating melanoma in situ as alternatives are imiquimod, which is a immune modulating cream, and that's given for 5 days a week for 6 weeks, or radiation therapy in consultation with a radiation oncologist. For invasive melanomas, for example, in this patient, surgery is required. So this patient had a melanoma with a Breslow thickness of 0.3 millimetres, and the excision was done with a 1 centimetre margin and a cervicofacial flap repair, as you can see on the right of screen. This is his wound 6 weeks later, and by 9 months, the scar had almost completely disappeared. So who needs a sentinel lymph node biopsy? If your excisional biopsy shows a melanoma with a Breslow thickness less than 0.8 millimetres, and there's no ulceration, and there are no mitoses per millimetre squared, sentinel node biopsy is not required, and a wide local excision is all that's needed to cure the patient. If the Breslow thickness of the melanoma is equal to or over 0.8 millimetres, or there is ulceration, or there are more than 0 mitoses per millimetre squared, at the very least, a discussion about sentinel lymph node biopsy needs to be had with the patient. Okay, so this patient had a melanoma of the right shoulder with a Breslow thickness of 1 millimetre, which was diagnosed on incisional biopsy by their general practitioner. Following referral to me, I booked them for a wide local excision and a sentinel lymph node biopsy. On the morning of their operation, they underwent a lymphoscintigram at a nuclear medicine practice where technetium-99 was injected around the melanoma intradermally, and the lymph node to which that melanoma would drain first was located by superimposing a SPECT scan on a CT scan. And so here you can see the SPECT scan with the sentinel lymph node located in the patient's left axilla. Then under general anaesthetic, I injected intradermal patent blue dye around the melanoma intradermally. And then at operation, in the patient's axilla, a radioactive blue coloured lymph node was located with the help of a sentinel lymph node probe, which is kind of like a gamma probe. It was sent to the pathologist for evaluation, And then the melanoma itself was excised under the same general anaesthetic with a 1 centimetre margin as per the guidelines. So when do we stage patients radiologically? We don't need to stage everybody radiologically. If the Breslow thickness of the melanoma at the outset is greater than 4 millimetres, or there is clinical evidence for metastases, being in-transit metastases, regional lymph node metastases, or distant metastases, or if the sentinel lymph node biopsy is positive, the patient should be staged radiologically. Radiological staging is done with FDG PET scans of the whole body and either high resolution CT or MRI of the brain. And here you can see a PET scan showing multiple metastases throughout the body. All those yellow spots are metastases. And on the MRI of this person's brain, you can see 2 obvious metastases that light up in white, one in each cerebral hemisphere. This patient had a melanoma of the scalp and presented with these little black dermal nodules going all the way down the back all the way down behind his ear and down his neck. They were about biopsied and found to be melanoma. These are what in-transit metastases look like. They are melanoma cells that have been held up in the dermal lymphatics where they grow. These 2 patients presented with palpable nodal metastases. On the left is a patient who had palpable inguinal lymph node metastases, and on the right is a patient with an easily visible and palpable right axillary metastasis. I did nodal dissections for both of these patients in order to clear their disease, and then they went on to have adjuvant therapy. More on adjuvant therapy soon. This is a intraoperative photograph during a laparotomy of a patient who presented with an acute abdomen due to small bowel intussusception. At laparotomy, I found multiple melanoma metastases on the serosal surface of his bowel, and multiple bowel resections needed to be done in order to clear those metastases. Melanoma is one of the only cancers that regularly metastasizes to bowel. Once staged, a patient will fall into 1 of 4 stages. Very simply, melanoma is stage 1 if it is a thin melanoma and it's localized to the skin. It's stage 2 if it's a thicker melanoma but still localized to the skin. If there are nodal metastases, whether they're occult nodal metastases or obviously palpable nodal metastases, the patient is stage 3, and there are substages in stage 3, A through D. If a patient has distant metastases, they're stage 4. Overall survival for patients with stage 1 to 3 melanoma is reasonable, with about 70% surviving 10 years after being adequately treated. And this was before the era of our new drugs. These drugs have revolutionized melanoma therapy and improved the quality of life and longevity of our patients, even those with advanced disease. BRAF and MEK inhibitors act to target the BRAF gene, which is frequently mutated in melanoma, particularly in young patients. For patients like this one with large liver metastases, rapid improvement is achieved just after a few weeks. As you can see in the PET scan in diagram A, the metastases in this patient's liver lit up brightly, and then after a few weeks of BRAF inhibition, those metastases became quiescent. Unfortunately, BRAF inhibitors, although they act rapidly, the outcomes are not durable and drug resistance occurs after about 1 year. Immunotherapy is the holy grail of cancer care, and we have progressed in leaps and bounds in melanoma. Directing the body's own immune system to target and kill cancer cells is what ultimately we hope will help to cure these patients. Anti-CTLA4 and anti-PD-1 inhibitors interfere with the melanoma's ability to hide from the body's T cells. Because melanoma is such an immunogenic cancer, because it has so many genetic abnormalities, the body's immune cells do turn on it, but the melanoma has developed ways to hide from the immune system. These drugs inhibit the melanoma's ability to hide from the immune system, and as such, the T cells then recognize the melanoma as foreign and attack and kill the melanoma. These results are often really dramatic, and 20% of patients who had widely metastatic disease in stage 4 are achieving long-term survival now. That's beyond 5 years and up to 10 years now. This diagram shows survival over 1, 2, and 5 years for patients with stage 4 melanoma from 1990 until now. So at the moment, you can see the 1-year overall survival for a patient with stage 4 melanoma in 1990 was between 25 and 35%. Then these drugs were introduced, and that 1-year survival improved dramatically. And so we followed these patients over time. And if you just ignoring the names of the drugs and just looking at the numbers, at the bottom you can see the 5-year overall survival is now two-thirds of patients will survive 2 years, and almost half will survive 5 years. So from a place where about a third survived 1 year, we now have almost half surviving 5 years. So this is all down to these new drugs. My friends at the Melanoma Institute of Australia are developing risk prediction tools based on massive Australian and US databases that you will be able to use in your offices to better inform the people that you care for about their prognosis. Now, after the acute aspect of our patient's care is done, follow-up is key, and 6-monthly skin checks, repeat radiological examinations, and the timely biopsy of suspicious lesions is absolutely vital. Now, these regimens differ with each patient and can be done by you and I in a coordinated way. Communication between specialists is key. All of my contact details are available to you, including my mobile number, and you can feel free to use any or all of them at any time. I'd just like to invite some questions now before we move on to the second part of the talk.
So the first one is, can you comment on increased autoimmune disease with the immune therapies?
Yeah, some of the immune therapies do have some pretty nasty side effects, particularly ipilimumab at high dose can have some bad side effects. In fact, people can die. People have died from this immune therapy. There is an increased risk of autoimmune diseases, particularly of the skin, gastrointestinal tract, and joints. These drugs are given by specialized melanoma oncologists who screen these patients really closely for autoimmune side effects. And sometimes they do need to treat those side effects with immune modulation, with corticosteroids, and or also stronger immune modulating drugs. I don't give these drugs in my practice from a surgical point of view, but the people who do give them have very well established paradigms for monitoring for autoimmune disorders.
Great. So the next question is, can you clarify what the mitosis rate means and its utility?
The mitosis rate is a judgment made by the pathologist who looks at a specimen of the melanoma under the microscope, and then establishes how many cells, melanoma cells, they can see dividing per square millimeter. And so what in the old AJCC 7th edition staging guidelines, the number of mitoses per millimeter squared played an integral role in staging the melanoma, and it was found to be of less importance in the new staging guidelines in the 8th edition of the AJCC guidelines. But it still is a marker of aggressiveness. So the more mitoses you can see per millimeter squared, the more rapidly dividing the tumor cells are, and the greater risk there is for local recurrence and regional and distant metastases. So it is a marker of aggressiveness.
Great. The next question is, what is the reason for increased melanoma in Parkinson's disease?
In Parkinson's disease, I couldn't comment on that actually. I don't know. I haven't heard of an association between melanoma and Parkinson's disease, I'm afraid.
No problem. What type of follow-up is required after excisional biopsy of stage 1 melanoma?
So by stage 1 melanoma, if the melanoma has been excised with clear margins and the sentinel node is negative for some stage 1 melanomas, then the patient should be followed up every 6 months for 5 years for a full skin check, a lymph node, so a full skin check, a check of the regional lymph nodes and abdominal examination. There's no radiological examination that's required for stage 1 melanoma, only clinical examination. The patient needs to be vigilant in terms of looking for skin changes in the interim period, and it's actually the patient and their partners who often find things before any of us do. And so education of patients in self-detection is one of the most important things you can do for them in terms of early detection of a second melanoma or recurrence of already treated disease.
Great, and we do have a question about whether a copy of the PowerPoint slides will be provided, and we will be sending that along with the certificate next week. So you'll definitely get a copy of the slides. That's all the questions that have come through so far, Dr. Sandler.
Thanks. I'll have to look up the association with Parkinson's disease. I wasn't aware of that. Okay, so let's move on now. So the next part of the talk is about soft tissue sarcoma. This is a very different entity to melanoma. It's on the absolute opposite end of the spectrum, really, in terms of incidence. Unlike melanoma, sarcoma is extraordinarily rare and only accounts for about 1% of all cancers in Australia. There are currently 60 histopathological subtypes, the most common of which are liposarcoma, leiomyosarcoma, undifferentiated pleomorphic sarcoma, and gastrointestinal stromal tumour. I should add fibrosarcoma to that as well. There are a number of non-modifiable and modifiable risk factors. Genetic disorders such as neurofibromatosis, Li-Fraumeni syndrome, retinoblastoma, and familial adenomatous polyposis increase patients' risks of developing sarcoma. Specifically with the fourth one, familial adenomatous polyposis, that increases the patient's risk of developing desmoid tumours, which are actually benign tumours, but they can be locally very aggressive. Environmental risk factors include radiation therapy, which increases the risk of angiosarcoma, of all sarcoma, sorry, lymphedema, which increases the risk of angiosarcoma, and infection with herpes, human herpes virus 8, which increases the risk of Kaposi sarcoma in patients who are immunocompromised, such as patients who have HIV and AIDS. Sarcomas have a variable growth pattern depending on their type and differentiation, and they can occur anywhere in the body. They tend to metastasize hematogenously, unlike melanoma, which tends to metastasize at least first to the lymph nodes. So sarcomas will spread first to the liver and to the lungs. There are a few that will spread first to the lymph nodes, but they are definitely in the minority. Examples of those include clear cell sarcoma, epithelioid sarcoma. The exception to this is rhabdomyosarcoma, which does occur more commonly in children. That can also metastasize to lymph nodes. So here are a few examples, and we're going to follow the journey of these two patients. On the left of screen is a patient who presented with an extremity sarcoma of the right thigh. This turned out to be an undifferentiated pleomorphic sarcoma of the rectus femoris. And on the right of screen is a patient who developed a fibrosarcoma in the extensor compartment of her right forearm. These are examples of extremity sarcomas. Just remember these because we're going to look at these patients a little later. These are examples of patients who have retroperitoneal sarcomas. Sarcomas of the body can occur on the body wall or can grow from the retroperitoneum. These examples are obviously very dramatic, but more commonly, patients will present with retroperitoneal sarcomas. They experience abdominal distension. Body wall sarcomas will present as a painless mass of the abdominal or chest wall. The radiological examination of choice for an extremity sarcoma is an MRI. It gives excellent anatomical definition, including the sarcoma and its surrounding structures, and is absolutely vital for operative planning. And this is an MRI of the patient that we saw before with the right thigh sarcoma. The tumour is clearly visible in white, with the surrounding muscles in black, and in the middle you can see the femur. The radiological examination of choice for retroperitoneal sarcomas is a high definition CT scan. MRI takes too long, and the motion of the bowel makes the anatomy difficult to interpret. Biopsy is really important for the therapeutic planning. The principles of biopsy is that it should be employed the least morbid method, using the shortest route from the skin to the tumour. The entry point should be marked, as it will need to, as the entry point of the needle or the knife for the biopsy will need to be excised. Definitive excision really needs to be kept in mind. So this picture here on the right of screen is a picture of a transverse incision used to biopsy a sarcoma of the leg. Excision of that skin will provide a management challenge for the reconstructive surgeon, because we'll need to do the excision in the long axis of the limb. So if the biopsy had been done in the long axis of the limb, that would have been a better option. Now, of the options available to us for biopsy, core biopsy is the one that's almost always used. Occasionally, incisional biopsy is needed. Fine needle aspiration biopsy gives too little detail, and an excisional biopsy shouldn't be done, because if a sarcoma is diagnosed on excision, it means that you probably haven't gone wide enough, and the re-excision will be needed for clear margins. Re-excisions, unfortunately, are associated with a higher rate of recurrent tumour. So the core biopsy should be ideally image guided. Core biopsies are low morbidity. They're very accurate because they give good architecture, and they're very cost effective as compared to doing an incisional biopsy under general anaesthetic. This is a picture of a CT guided biopsy of a presumed bony metastasis from the patient that we saw before with the thigh sarcoma. It turned out to be negative. But even if you think a lesion is definitely a sarcoma, biopsy prior to treatment should be carried out in order to rule out alternative diagnoses. Any of these lesions here could be sarcomas, but as you can see in the picture on the left upper, this is a lymphoma which can be treated without surgery. The next one on the right hand side is a germ cell tumor, which does require preoperative chemotherapy, but it's a different regimen to the one you give for sarcoma. Left lower is a schwannoma, which doesn't respond to chemotherapy or radiotherapy and just needs surgery. And to the right lower is a liposarcoma, which needs preoperative radiation prior to surgery. Staging a sarcoma includes a clinico-pathological assessment of the size of the lesion and its histological grade, and then a PET scan to check for the presence of metastases. A PET scan is the most sensitive way to check for metastases prior to therapy. So how do we manage these? Resectable localized disease is usually treated with preoperative radiotherapy followed by surgery and then postoperative chemotherapy. We give preoperative radiotherapy to localized lesions because it decreases the rate of their recurrence. And then we give postoperative chemotherapy to deal with any occult metastatic disease. Unresectable and metastatic disease is treated with a combination of chemoradiotherapy, and we only do surgery if that lesion then becomes resectable. Unfortunately, if a patient presents with metastatic disease, they're only very rarely cured. So on the right of screen is the MRI of the patient with the right arm sarcoma, and on the left of screen is an operative photograph prior to resection of that sarcoma. Her skin has been darkened because she received preoperative radiotherapy. On the left of screen is the excision. You can clearly see the radius and the ulna. The skin has been taken with the tumour as well as the intraosseous membrane. This leaves a very large defect, and on the right of screen you can see that an anterolateral thigh flap was marked, including its blood supply. That flap was raised and used to fill the defect. This operation was done in 2015, and this patient is alive and well without any evidence of local recurrence or distant metastases. Okay. Now, retroperitoneal sarcoma surgery can be quite dramatic. In this CT scan, you can see a retroperitoneal sarcoma which has pushed the left kidney forward. Okay, this is an operative photograph showing the tumour mostly dissected out. This is a laparotomy photograph. The patient's abdomen's open. You can see the tumour very clearly. On the bottom of the screen, between the two retractors, is the patient's kidney, and it's attached to its pedicle and has a good blood supply. And to the right side at the top of the screen, you can see the patient's colon. And that tumour was a liposarcoma. Importantly, not all sarcoma requires surgery. This boy presented with a mandibular desmoid. You can see the mass just under the left-hand side of his mandible. In order to resect this, he would have had to have had a left hemimandibulectomy, which is an awfully morbid thing to do to an 8-year-old. So we treated him with vinblastine and methotrexate. To the left of the screen, you can see an MRI showing that white area, which is that large tumour that we saw in the clinical photograph. The MRI on the right of the screen shows what it looks like 6 months after we commenced methotrexate and vinblastine. The next MRI after that showed that it had completely resolved, and he has now been 18 months disease-free. It has not recurred. Prognosis of sarcoma depends on many variables, including the age of the patient, the size of the tumour, its grade, whether it occurred in the retroperitoneum or in an extremity, what its histopathology is, whether it's multifocal or not, and the completeness of the resection. These variables can now be fed into a prognostication tool called the Sarcolator, which was developed by an international team from Italy, Canada, the UK, the USA, and France. Now, the variables are entered into the app, which is available on your iPhone or your Google phone, and an overall and disease-free survival prediction can be made. This is really useful for communication, accurate communication regarding prognosis for patients and for their families. Now, sarcoma is really rare, and there are only few clinicians that have a lot of experience with it. There are various units around the city, including at the Prince of Wales Hospital, the Chris O'Brien Lifehouse, and Westmead Hospital. They're the largest units in the state. Sarcoma units are multidisciplinary, involving large teams of experienced clinicians, but for most patients, the GP is the linchpin and the most consistent clinician involved with their care. From diagnosis to management to follow-up, sarcoma can be managed in a share care model, just like melanoma can. Each patient's journey is unique, and so there's no real generic follow-up to be advised. You have to tailor the follow-up to each patient's circumstance. Broadly speaking, after surgery is complete and after they've received their post-operative chemotherapy, we follow patients up 3 to 6 monthly, and this can include clinical review, radiological review, and pathological review with biopsy of any suspicious lesions in order to catch a recurrence or a metastasis early. So I think we've covered a lot of ground in the time that we've had together. We've covered the clinical assessment, the diagnosis, and the broad principles in the surgical and non-surgical treatment of melanoma and sarcoma. And we've also covered how we calculate the prognosis of these lesions, including some online tools and some smartphone-based tools that can be used in your practices. I really look forward to managing these patients with you, and I encourage you to get in touch with me if you have any queries or questions regarding management of these patients. I'd like to invite any questions with regards to the second part of the talk, and if anyone had a question on melanoma, I'd invite those as well.
Okay, yeah, so if everyone can ask their questions in the question section of their toolbar. One that's come through is regarding the mandibular desmoid that was treated with chemotherapy, just about what kinds of patients that would suit and the success rate of using that method.
Okay, so desmoid is a very difficult entity because we don't really understand it. If a desmoid is clearly surgical resectable and morbidity can be minimized, the first option would be then to resect it. There are a whole range of therapies that are available for desmoid. We don't really understand why some desmoids respond to some therapies and other desmoids respond to others, and others don't respond at all. In broad brushstrokes, 30% will get better, 30% will stay stable, and 30% will progress and can actually kill the patient. The chemotherapeutic regimens that have been found to probably be effective include vinblastine and methotrexate, which is actually quite low morbidity chemotherapy with fewer side effects. There are other novel agents like sorafenib which can be used. Now, for this particular boy, we monitored him very closely. We started him on the chemotherapeutic regimen and found that he stabilized for 3 months and then responded very quickly. We have no idea if he responded as a consequence of the chemotherapy or whether the lesion just would have disappeared on its own anyway. In contrast to him, there have been two other youngsters who had desmoids that one was resected and progressed, and one presented in the base of skull and was unresectable at presentation, and both of those patients unfortunately succumbed despite us trying all of the chemotherapies that we knew of to use. And so I wish we understood it more. It's an area of research that someone could really make their mark on